Thanks everyone so much for joining. I am Bobby. I'm the co-founder and CEO at Elion. I'm thrilled to be hosting today's conversation on what it takes to adopt AI scribes at scale. So for those of you who aren't familiar, just about Elion really quickly, we're a healthcare technology research and intelligence company. Our mission is to make it easier for health systems and provider organizations to deliver better care through the adoption and use of cutting edge technology. So we've got a fitting topic today, given that AI scribes are by far the leading use case for generative AI in healthcare. And as most of you have likely experienced, there's been no shortage of buzz around ambient scribing, but most of the conversation today has stayed at the surface level. So, really with this panel, our goal is to get behind the scenes and into the details on what it takes to choose the right partner, to get clinicians to actually use it, and to prove that it delivers value. So with that, I'm going to turn it over to the panelists to introduce themselves. So Brian, I'll start with you real quick.
Had to come off mute, sorry. Yeah, I'm Brian Frost. I'm the Chief Medical Information Officer at McLeod Health, which is a 7-hospital system in South Carolina. Also do telehealth, and I'm a practicing emergency room physician.
Great. Abby and Suryan, I'll jump to you guys.
Hi, thanks for having me. My name's Abigail Baldwin-Metzger. I work at Memorial Sloan Kettering Cancer Center in New York, where I currently oversee a team that's focused on digital strategy, implementation, and evaluation of emerging technologies.
Hi, everyone. I'm Suryan Goyal. I'm a product manager at Sloan Kettering as well. So I work alongside folks like Abby to help lead implementations and evaluations of different technologies.
Hi,
Great.
Paul Lukac, pediatrician by training, and I'm the Chief AI Officer at UCLA Health. And so at UCLA Health, we have about 5,000 ambulatory physicians who are all very interested in using this technology.
Great. So let's dive right into it. And we'll start on the vendor evaluation process and kind of pilot experience. And so, Brian, I want to start with you, since I think you took a particularly unique approach to evaluating prospective ambient scribing solutions. So can you just start by walking us through your process and some of the key learnings?
Yeah, this was an interesting process, and I'm actually kind of amazed that the vendors allowed us to do this. We were very sensitive to the fact that we didn't want to just pick a vendor based on groupthink or what other people were doing. We wanted to remove as much cognitive bias from the decision making. And the process I'm about to tell you was surprising to us. In fact, I was biased and didn't realize it. I went into this process pretty sure of who I was going to pick as an AI scribe vendor, and I was wrong. So this is what we did. We filtered through all the known existing at the time, this is about a year ago, scribe AI vendors, and we filtered out a bunch of them based on data security concerns or scalability concerns. We narrowed the field down to the top 4 vendors, who all of you in the room would probably say, yep, that's some of the vendors I've considered. I wrote out 15 very detailed patient scripts, and we had actors come in and play patient. And I had 3 doctors. I had a primary care doctor, a cardiologist, and a vascular surgeon play doctor. And these scripts were fun. They were very complicated. They had all the accents, which, by the way, the hardest accent to have the AI solutions learn is the Southern redneck. So we had a lot of Southern redneck accents in there. We had interruptions, really tested the system. One of the scenarios, just to give you an example, we had the patient who came in and knew what they needed. They needed a prescription because they had checked out Google, and Google told them that this is what they needed. Another script, I kind of flipped it on its head, where I had the vascular surgeon specifically be a jerk to the patient and very dismissive of the primary care doctors who were sending the patient to him, just to see how the AI would handle that. So that was the first phase of the experiment. Out of that, we had 3 groups of people rate the notes. So just so you know, the vendors had to record these interactions, all 15 of them, in real time, and they had to send them, the notes, to me unedited immediately following the interactions. We had a group of physicians, a group of rev cycle, and a group of patients review the notes, and they were really looking for readability, coding, how well they were able to code off of it, and clinical relevance. So out of that, we went to phase 2, where we had the 2 leaders of that first phase come back demonstrate their solution within Epic to a broad group of physicians. And they were really looking at usability. How would it impact my daily workflow? And then we surprisingly picked a vendor that in fact, I almost didn't even include in the process because I didn't think they were worth looking at. And they turned out to be fantastic. We just went live with them, I think about 4 or 5 months ago, and we're now scaling from our initial pilot of 35 doctors up to around 150. So that's our story.
Cool. Super interesting. And Paul, I know you took a really structured approach to your evaluation as well. I believe running a randomized controlled trial that compared a couple of vendors head to head. Can you talk through your process as well and the criteria ultimately led you to choose one over the other?
Yeah, so at UCLA Health, we of course did our due diligence. We made sure that we met with quite a few of the top players because we do want to see what's out there. And then we settled on two that contrasted in important ways. And so we said, okay, why don't we compare these two? We like the teams, we like the products, but they are subtly different. And we also have an excellent research team at UCLA Health. It's called our Values and Analytics Solution Group. And they said, hey, why don't we run this as a gold standard, a randomized controlled trial? That way we'll get really good results coming out of it. Will help our decision making. And so that's exactly what we did. We started this last fall. And what does that mean? So we basically had 2 intervention groups. We had one group that got one of the AI scribes, another group got the other AI scribe, and then there was a third group, which was the control group, and that was unfortunately the physicians who didn't have anything for the first 2 months of the trial. Though we did make sure that they had access after because we wanted everyone to try it. But when we came out of that RCT, the also quote unquote a pilot, we had really actionable data to act on. So even in a short period of time, I will say both of the vendors performed quite well. We were very happy with the results across the board. We saw some efficiency gain and time spent writing notes, and then we saw improvement in what I would call like the psychometrics across the board. So things like burnout and work exhaustion and task load. It was very clear to us that people who had access to either of these AI scribes really had improvement compared to the control group. And again, it was in quite a short period of time that we saw this.
Got it. And what were ultimately the key criteria that led you to choose one over the other? It sounds like both performed pretty well.
They did, for sure. I can't point to any one particular thing. I think some things that resonated was that one of the vendors, they're a startup like many of these companies are, and they were very dedicated to this core product and very good to work with and responsive to doing pilots and other units beyond just the ambulatory setting. And beyond that, this other vendor had a very vocal group of super fans because of they particularly liked this one. And it for what it's worth, this one was a little bit better for the efficiency metric, so the time saved. So it was a combination of things, and we I can't say that this one was so much better than the other because again, the core product was very good, but we were happy with our decision and continue to be so today.
Gotcha. And then one quick, we've got some Q&A, and we'll do some of this interspersed and some of this at the end, but I think it's a good question. How did you actually evaluate the psychometrics as part of your study?
Sure. We used validated survey metrics. So they're ones that are proven to be good measures of things like burnout and work exhaustion, et cetera. One of them is called the Mini Z 2.0 survey, and that has been time tested to be a good marker of physician burnout. The other is called the Professional Fulfillment Index, and we used a subscale of that called work exhaustion. And the third survey element is called the NASA task load. It's a derivative of this instrument that NASA used historically, but it's been adapted to use in healthcare. And what does that look at? that looks at directly the stress that a provider is feeling from the use of the electronic health record. And so we did all of these by sending them out via surveys. So pre-pilot, pre-RCT survey and post-RCT survey.
Got it. Abby and Srian, I want to come to you because I know you guys recently wrapped up pilots with a couple different vendors. So I'd just be curious to hear about that experience, what worked well or what didn't work well, and how you designed your pilots, and if there's anything that you would change now looking back.
Sharon, you want to kick us off and talk about the design of the pilot?
Sure, yeah. We did pilot two vendors sort of head to head. We started with one, allowed them users to use it for about 3 months, and then we kicked in with the other vendor, and users had access to both at the same time to sort of compare and contrast. Unfortunately, we were not integrated into our EHR because we were in the middle of our move to Epic, which we just completed this year. But at the time of our pilots last year, our clinicians were using both AI Scribe vendors unintegrated, which did end up being a huge barrier to adoption. But even so, we tried to reiterate that the focus of the pilot was, how is this working in oncology? How is this processing the really complex conversations you're having with your patients around their disease progression and all the nuances and complexities with cancer care? So given that sort of framing to the clinicians, we got great engagement from them. We also got really great engagement from both vendors. They really were great about processing feedback from our users and actually incorporating that into like new releases monthly, which we were really happy to see, and something you don't always see in health tech. And then I also felt like our feedback loops and routine data collection was really strong, which again allowed us to take actionable steps to sort of offer elbow-to-elbow support to clinicians to increase adoption, or send stuff over to the vendors to help fix certain issues quickly.
Yeah, just add, I mean, you asked what things we might change is next time I might not pilot 2 innovation solutions during an Epic build and implementation. So you can imagine we were in the midst of heavy change management and building out our new core clinical platform, which it didn't deter our users from being engaged, but it was definitely a complex situation to be in when we're trying to decide between 2 vendors of an innovative technology. So I would say if you can avoid that, I probably would. Otherwise, it turned out pretty well. I mean, another couple of things I'd just add to make a pilot successful is I would have liked to have a larger cohort of participants. Our N was a little small, our denominator was a little small. I would have liked it to have been a little bit larger, if possible. I think we had some good, mixed methodologies for metric collections with both, using quantitative and qualitative data to help us make our decision with some good, clear criteria, and got some good feedback on which solution our end users wanted to move forward with. I think we also really focused on a company that was very supportive, was very collaborative, and also had a really good roadmap, because we were really interested in doing some innovative work in the ambient space, which I know we'll probably talk about as a future question, but we wanted that to be a core piece of criteria when we chose who we worked with.
Makes sense. I want to keep moving through the process. We talked a little bit about evaluation pilots, and I want to start to talk about rollout and adoption. And so, Paul, I know you're now in the process of rolling out the vendor that you're working with at scale. Can you just talk a little bit about the process you're going through and any learnings about what's working and what isn't?
Mm-hmm. We ended our RCT in March, and so we continued on with all of our pilot users, which was about 200 physicians. And we just started doing this like expansion phase, which we're doing in monthly waves, essentially. We did our first one this month of about another 100. And I anticipate in July, based on like our intake numbers, we're probably going to have another 600 or so in July. And so the process that we're going through is really meeting this significant demand, but also making sure that we're doing really good training and onboarding. We do make our training mandatory. I don't think there's a way for you to be able to use this tool without receiving that training. But secondly, we also incorporate into the training the conversation that we have around AI and healthcare, and especially things that come from LLMs like chart summarizations and generative AI because it's imperfect. We can see errors with it, like omissions and inaccuracies and whatnot. So it's all a very important part of training. And that I think the training is not something to be underestimated, and that it's, even though it seems quite simple, you turn on your phone, you start a recording, a note magically appears. It really goes a lot beyond that. I would say what's working, and again, this goes back to training, is it's not just a one-off session that we do in a short period of time after we do that first onboarding period. We do add-on things. We have this thing that we called advanced features with super users. And so our vendor walks us through how to customize within their app. And then we have super users who are very savvy users of the technology walk through basically how they use it and what they would recommend for their colleagues. And we are definitely leveraging the offer from our vendor to do elbow-to-elbow support. So whenever they are in town, they set up shop in one of our clinical locations where there's a good cluster of physicians, and they will come see them where they work.
Got it. And I know, side note, I know we got a couple requests about using vendor names. I'll take this on myself. I asked folks not to kind of share the specific names they're comparing and contrasting. Panelists can mention who they're working with if they'd like to as well, but we are kind of being just a little bit, just want to be respectful there. So I just wanted to clarify that. We got a couple questions on it. Brian, I want to come back to you because I know you've seen through your process particularly high adoption rates. I think you said 76% of clinicians who have tried the solution continued to use it. So I'm just curious if there's anything specific that you think has driven this success.
Yeah, so you should know that we were able to pull this off with a very small group. It's literally myself and 2 others in the organization who are covering 7 hospitals. And I went into this whole project with the thought in the back of my head, there's that Maloney's 16% rule of diffusion of innovation. Some people call it, Malcolm Gladwell's the tipping point. Until you get to 16% of the organization, it's an uphill battle to get people to take on this technology. And like Paul said, it's not as simple. Like even if you think back to the days of Dragon Medical One, there were some barriers to get people to do it, but it was much lower than implementing an AI scribe. And so some ingredients that were really key. Number one was senior leadership and the messaging. We were very consistent between the senior leadership, operations, and then the IT clinical informatics department. We were doing this with them, not to them. One of the messages that our CEO told the physicians is, we do not want you to see more patients with this technology. And they heard that loud and clear, and they loved to hear that. And it wasn't until we started getting our KPIs back that it became pretty significant. Several of our doctors would get about an hour and a half to 2 hours back in their day. And I would always tell them, don't go see more patients with that time. All that's going to do is perpetuate the burnout problem. So spend more time with your families, eat lunch. Instead of taking 7 minutes per patient, spend 12, enjoy practicing medicine. And that's what we want you to do with it. So we concentrated on certain doctors. We found the ones that were the champions. And I'm interested to see what the other panelists say about this. I couldn't predict who would be a champion of this technology. There would be a doctor that I was absolutely certain would adopt this, would love it, and they hated it. And I'd find one that I didn't even want to have in the study, in the pilot, turned out to be the greatest champion of all. So once we had those champions, we actually went around with a little low-tech video camera and we recorded testimonies, and we put that out there. Medical staff that start to see their colleagues being able to leverage the technology and they hear about their KPIs, got people's eyes open. And now it's you've gone on the other side of that chasm, and now people want to get on board. So it was uphill for probably 2 to 3 months, but once we started getting the KPIs coming in and we started advertising, made all the difference.
Got it. We had a good question in the Q&A around adoption metrics. So they were asking specifically about weekly active usage for user percentages. I don't know if that's what you guys look at, but is there a particular metric you're looking at to assess adoption success? And I'd be curious kind of what level that that's at and how that's trended over time.
Yeah, I wouldn't call someone to have adopted the solution if they didn't continue using it 30 days, 90 days afterwards. So we wanted to see doctors who are still using it at moderate to high levels. It was actually a 60-day where we considered them to have adopted. And we also wanted to see some metrics. And I'll say something that's, I think, kind of interesting, especially for the physicians. If physician burnout is a disease, the solution or the medication to treat that disease was this product that we implemented. And the number needed to treat was almost 1. Of the doctors and the providers who implemented this, almost 100% of them got significant returns, whether it was pajama time reductions, time on the weekends, RVUs went up significantly, and I'll talk about that in a minute. But something we did not expect was patient satisfaction scores, and I'll talk more about that later.
Great. Paul, for you, anything on the adoption metrics that you've been looking at?
In terms of physician usage?
Yeah.
Yeah, so it's interesting. There will always be a certain number of physicians who are just not going to use it, regardless of how much training or reach out that you do with them. And I put that number probably between 10 and 20%. And there's a variety of reasons for that they don't really like the technology, it doesn't fit in their templated notes, or maybe it doesn't work for their specialty. So that group exists. Beyond that, I think there's at least for us, there was a similar other end of the distribution curve who are very high users. So they use it pretty much every encounter now. I would put that number somewhere between 10 and 20%. And then there's everything in between. I think our usage rate ended up being about 30 to 40% of encounters our physicians are using this tool. And then, of course, the way that these tools are paid for currently, the cost structure is a fee per user per month. So we want to be good stewards of the technology as well. And if someone is not using it after 90 days, they haven't used it a single time, we do inactivate those users and we give them notice.
Got it. I want to shift gears a little bit into results and impact. And so Abby and Siri, I'll come back to you. One of the things I'll say we've heard in some of our conversations with health systems or provider organizations, over the previous months is mixed feedback about the quality of ambient scribes, really highly specialized areas or subspecialties. And so I'd just be curious about your specific experience with this at MSK.
Yeah, I can kick off there. So definitely we had some very interesting trends both at the service level and clinician level. So like hematology, you might think different of the product versus head and neck surgery. But then within hematology, 2 hematologists love it. The other one thought it wasn't detailed enough and wasn't really usable. Some folks felt like the AI drafts were 80% usable. Some felt like it was 20%. And then just generally some more specific feedback. Many of our oncologists felt like there wasn't enough detail in the documentation of sort of risks and benefits of the type of interventions the clinician may be proposing to the patient, the associated toxicities, mitigation strategies, et cetera. Obviously, things that only come up in oncology visits when you're talking about chemotherapy versus radiation oncology versus surgery. And so many felt like the lack of detail there was concerning. But then there were also really hyper-specific concerns as well. Like our radiation oncologist felt like it was not correctly transcribing the clinical staging of the tumor, which is typically a collection of like numbers and letters. So obviously very specific to them. And so processing that feedback was interesting as well. So overall, yeah, totally mixed feedback. Definitely agree with Brian that we had some champions going into it that actually didn't end up being the highest adopters, but then we had some other users who were brought in organically that ended up being our highest champions. And now that we're moving to full scale implementation, they're sort of our biggest cheerleaders, which is great to see.
Yeah, I'll just add is we're an oncology hospital, so it's not like we have primary care or other non-specialty groups. And with the complexity of cancer care, which is multimodality, longitudinal care, we're seeing these patients for a long period of time on complex treatments. the reviews are mixed, and I think all models still need to be refined to get in their ability to be better in the oncology space. And so I think we'll see that over time as they get better and better. We have a partner who's willing to really work in that space with us, which I think is really important as you're choosing a person that you work with or a company that you work with as well. I think this is also a good place to bring up that that's why there's always human in the loop. So we need to make sure that whatever the output is, the clinician is reviewing it. They're making sure that we're capturing all of that nuance and the importance of the care of the patient so that it's captured in the note, and then it is appropriate to be entered into that medical record. I also think we'll see over time, like if ambient turns out to be better a solution for certain types of providers and certain type of specialties and not for others. There's been some new literature out there in the pediatric space that had a lot of positive outcomes. We're looking to really publish for the oncology space. So more to come over time as the solution is used in more specialty areas like the oncology space for us.
Got it. Paul, I want to come back to you. Again, really focusing on kind of the impact and getting into ROI discussion. So I know, alleviating physician burnout was for many a key driver to the rapid adoption of AI scribes. But now, at least for many systems, there's increasing pressure to justify the expense of these solutions from a direct ROI perspective. So I'm just curious how you guys have thought about this at UCLA.
Bobby, ROI is very important, and it's not just limited to scribes. I think it's using AI in general because it's expensive, and we certainly don't want to add like bloat to our healthcare system in this country. But also, the economic forecast is uncertain right now, so we want to make sure that the tools we invest in, we're seeing that return. And I don't think we're at scale with this yet, where we have like very direct metrics that we can show that return on investment. But we did do, as part of our early analysis, we tried to tie it to burnout. And leveraging, if you look at existing research, there is a cost for health systems associated with physician burnout. And the study that we quote is burnout costs a health system about $8,000 per year per physician. And this is for a variety of reasons: decreased productivity, physician turnover, et cetera. If you apply that to about 1,000 physicians, which will probably be at 1,000 by next month, that's something like $8 million to your health system per year. In our RCT, we saw about a 20% reduction in burnout prevalence. So if you do some simple math from that, that would be saving us over the course of a year somewhere around $2 million just in burnout, the decrease in burnout prevalence. I do expect to see lots of downstream positive, financial gains from this as well, both patient experience wise. There's value in that, of course, and other things. A lot of these companies are working on, CDI, clinical documentation improvement, charge capture, or what have you. And then just to finish my answer, I did notice a lot of people were asking about what vendors we're using. I think I feel comfortable in saying that we're currently using Navla at UCLA Health.
And I feel comfortable too. We're using a bridge at MSK.
And I'll just tell y'all, we chose Suki.
Awesome. Hopefully that helps.
It's a good broad representation, actually. So yeah.
There we go. Brian, I want to come back to you on the patient satisfaction front. So I think that's a particularly kind of interesting topic that doesn't often get enough airtime in this. So can you talk a little bit about your experience along those lines?
Yeah, so we had two KPIs that came back that we didn't really expect. So one was the financial. We actually had a very hard ROI with this that I'm hoping to publish. Actually submitted the manuscript this morning to JAMA, so we'll see if they accept it. But the KPIs around patient satisfaction, I wasn't even measuring. We have a team at McLeod that focuses on patient satisfaction, and they do initiatives throughout the year. They came to me and they said, "What have you done?" And I was like, "What do you mean?" They said, "We've done lots of initiatives that's raised the patient satisfaction scores by maybe 1%, but it wasn't sustainable." And the providers that we launched Suki with, for two of the NRC questions, one was the question, the provider listened carefully. That metric went up by 6.3%. And the other question, did you trust the provider with your care, went up by 5.9%. And I think it's because the way we onboarded these providers, we were very clear with them that they had to change the way they practice. So what I learned was that the providers who adopted this technology are flexible in the way that they practice, and they're really good at the very end of the encounter doing maybe a 20 or 30-second summary so that the AI can hear it and does a really nice assessment and plan. But the other advantage is the patient feels this shared decision-making process. And I feel like they're engaged more, and they feel like the provider cares and is listening, and he doesn't have his back to me, he's looking me in the eyes. So that was a KPI that we did not expect to see, and we did. So that was exciting to see.
Super interesting. And then on the hard ROI front, I mean, I know you mentioned a little bit ago, you weren't specifically focused, certainly on physicians seeing more patients or anything like that, but is there anything you've done in terms of kind of the hard dollar ROI measurement?
So again, like I said in the beginning, we were very focused on one of our CEOs actually over the ambulatory group, the senior vice president of the ambulatory group, talked to the physicians and said, we're not doing this for you to get more revenue to the organization. They emphasize, do not see more patients. We want to mitigate burnout. And so I wasn't really too worried. As long as I broke even, I would be happy. Before I get to that, I want to share one of the problems with our pilot. So I would say one of the limitations on our pilot is we made the decision early on to only include providers who were at the 70th percentile or higher for efficiency. And that decision came out of fear. And the fear was what Paul mentioned earlier about the product's cost per provider per month. We were nervous that we weren't going to break even. And so we thought, well, let's just use the very efficient providers. Well, that's a dumb decision because the last person who needs an AI assistant is the very efficient provider who already has low pajama time. When we changed that decision, started giving it to lower productive providers, and the sweet spot was around 30% to 60%, those providers excelled. But so what we found is a 9% shift in our level 4 CPT codes. We saw those go down and they were replaced by level 4 and level 5. And I think it's because the number and complexity of problems addressed was being elevated because Suki was capturing all that. It was also suggesting ICD-10 codes. So we had higher HCC capture, but just focusing on the shifts in CPT code, we saw $1,000 per provider per month net after the subscription costs. And there's one more thing I need to tell you here. The reason we were able to scale it to the lower productive providers was the vendor made a decision. So Suki came back and said, we're not going to charge you this fee per month. We're going to do encounter-based pricing. And that was a huge game changer, not just for the organization, but also me personally, because the last thing I wanted to do was get in the business of swapping licenses. I am not interested in that business. And I found like some of my OBGYNs and oncologists, they love the product, but only for their new visits or their GYN visits. And so if they're only using it 10 times a month, I want that. I want them, and they pay a very small fee per encounter with a cap that was lower than what the other vendors, the big guys, were charging. So I was just thrilled with that because it causes the vendor to be on the hook and they're aligned, their interests are aligned with our organization. So if we don't scale it, they don't make any money. And so they're very invested in making sure our providers adopt it.
Super interesting. Abby and Seren, I know you guys are just starting to roll this out at scale, so this will be a little bit more forward looking, but I'm curious what you're going to be looking at specifically, metrics in terms of tracking the success of your rollout, as well as ROI.
We have a pretty robust evaluation plan with not only to meet the KPIs associated to our business case, but also to support future publishing. And so we are focused on collecting both qualitative and quantitative data. We do have a focus on financial impact, maybe not necessarily return on investment, because that's to be determined, but financial impact. We'll be looking at like work RVUs, time to document, average level of service. working very closely with our financial colleagues around those metrics. You mentioned burden and burnout. We're using the Mini-Z and the NASA TLX to assess both of those metrics, which I think are very important. We'll be collecting, metrics related to clinician experience, EHR time. Very interested in, feedback related to any hallucinations. So being pretty technical around what's happening with the model, doing technical model monitoring as well. It's a pretty robust plan. We need to be careful how large our evaluation becomes. And then, of course, utilization and adoption. I know we talked about that earlier. We had originally set a utilization target and worked on a specific definition and numerator and denominator for each one of our areas, whether it be our urgent care versus inpatient, outpatient, or even burst specialty. We actually moved away from that target for the moment. Want to see a little bit see more what happens over time as people start utilizing the technology. And we are at an enterprise kind of licensed model. So we'll see how it goes if we start to think about focusing on setting targets for people. Like Brian said, we also don't want to be in the business of having to move licenses around to people, especially as we onboard more clinicians and APPs into the mix. But we're definitely going to be collecting metrics around it to see what those types of impacts and scales look like. Anything that I missed, Arian, related to evaluation or metrics?
I don't think so. We're also hoping to look at the patient perspective as well. So maybe survey a question of patients that have had ambient use in the visit and understand any concerns or benefits to them there. Also, Bridge does offer like a patient visit summary that summarizes the visit at a lower reading level for patients. So may try to pilot that as well at some point. And then just looking for any sort of validated tools to also measure clinician trust, documentation quality, stuff like that. So we have a couple of those that we're reviewing.
I want to talk about roadmap a little bit as well. We haven't really gotten into that so far. And so, Paul, I know you previously mentioned in our conversation that roadmap wasn't as big of a consideration for you, at least initially when choosing a vendor. Whereas, Brian, I think this was a particularly critical component for your evaluation process. So I'd just be curious from hearing a little bit from both of you on kind of how you thought about the importance of roadmap and kind of maybe specifically within that, what you were looking for. Paul, or Brian, you go for it.
I can start. Excluding Microsoft and Solventum, I think all of the main players in the space are health tech startups, right? And they're all still relatively in their infancy. And I bet if you asked any venture capitalist in the world, they would tell you that it's very difficult to forecast the future of a health tech startup or any tech startup. So I know that, with that knowledge, I would say that I just walk into this knowing that the roadmaps and projections are not always going to be achievable. At the same time, I've found that there is a pretty decent level of overlap in what each is trying to do. And so we felt comfortable, going with this tool that we were very happy with the core product. And this market continues to evolve and quite quickly. So maybe a year from now, when we're considering other solutions, which I will be always considering other solutions, we may decide that Nabla is not right for us anymore. But I still think it's very early in the evolution of these additional features, and so I'm fine with the wait and see approach.
Yeah, so we entered this space honestly, I'm not interested in the note output at the end of the day. I think within a few years, all the vendors are going to have the same type of note. I do want them to work harder on the CDI component. I do feel like it's caused us to step backwards. I'd love to have more CDI aware notes. But putting that aside, I do think this is going to evolve and all the vendors are going to have pretty much a commodity when it comes to the note. The tech stack was the most important for us because we felt like switching costs were going to be fairly significant. And we wanted to get embedded with a vendor whose tech stack was going to take us to the next level. The areas that I'm interested in, so anybody on the call who uses UpToDate and hasn't heard of open evidence has an exciting adventure before them because UpToDate is not very up to date. It takes me maybe 10 minutes to research on my clinical shift a question. Whereas I can ask open evidence that same question and get the same answer with transparency, knowing exactly where it came from. That clinical decision support piece is something we were very interested in with Suki. The thing that's interesting about Suki personally is it's a digital assistant, and they've poised themselves to come alongside the provider and do all the things that create burden. So clinical decision support was very important to us. For instance, I'll give you some. They're working on summary, which LLMs are really good at doing a chart summary, but I want a chart summary specific for the vascular surgeon versus the pediatrician versus the spine surgeon. If each of those specialists asks for a summary, what's happened to my patient in the last 12 months, they're going to want very different information coming back in that summary. So Suki was working on that. Conversational AI was also a big deal to us. We feel like the future is going to be iterating and talking to this product. And so I'd love to be able to, in real time, ask it clinical questions. What's the differential diagnosis? What's the current evidence-based treatment for XYZ? And have it answer me. I think that's where the future is going. And I really spent a lot of time looking at the tech stack of the various vendors, and that's why we chose Suki.
All right. And Abby and Surian, for you guys, as you're thinking, I know you're just, again, in the early stages rolling out the scribing component, but as you're thinking about kind of additional extensions, I guess what downstream areas are you most excited about? And what, if any, are you starting to plan for?
I think we're excited about the nursing solutions that are coming down the pipe for more general availability, which I think will make a big impact on our nursing population and also patient experience. We have a lot of interest in clinician decision support, as Brian just mentioned, like how can we leverage ambient AI solutions to support clinician decision support. We're also very interested in thinking about like ambient in the room, we call it, or ambient as a service. We have some new buildings. We have one new building opening up for MSK, and we are very interested in thinking about if we put ambient in the space or in the room, how can we leverage that to create a better environment for our clinicians to capture the data they need, the conversations, and have that be part of their nodal medical record. So we're looking into some of those innovative solutions now. We're also doing some focused work related to clinical trials. So we're really interested in thinking about where these vendors will go in the space when it comes to being able to work with the complexities of clinical trials and capturing clinical trial data.
Super interesting. Surian, anything you want to add?
No, great summary. Yeah, I think near term exploring nursing and clinical trials is a priority for us.
Got it. And I'll open this one up to the group. I think a lot of the vendors in the space are really starting to focus quite a bit on the revenue cycle side of things, and particularly CDI and how that can contribute. So I don't know if Brian or Paul, Brian, I know you just mentioned CDI in particular. Would be curious to hear your thoughts on the impact here on the rev cycle piece in particular.
Yeah, like I said, I feel like we've stepped backwards because what they've done is basically just put a blob of text in my medical decision making, and it's not CDI aware, which is really important. It needs to say things in a way, not just from a medical legal perspective, but also from a billing coding perspective. I want it to say the phrase so my coder picks up on what I'm putting down, and I get credit for that CPT code and the facility charges that go along with it. So I think they need to work on prompt engineering around the language models to get better at this.
Paul, any thoughts on your end on the revenue cycle front?
We have not yet trialed Nabla's features, which I think are still kind of like beta, but what I'm anticipating is like a CPT suggestion and CDI real-time CDI too. So I think on the calendar for 2026. So hopefully we'll get those things soon. But we at UCLA Health we make sure we validate everything before we use it. So we'll go through a period of testing and making sure we're comfortable with the output and tolerant of the risk before we go at scale.
I'll do a couple lightning round questions and then maybe open it up to some broader Q&A. Start with a general one. What's, for whoever wants to start, what's one lesson you wish someone had told you at the very beginning of your AI Scribe journey?
I'll start. It's not a silver bullet. It is not the perfect solution for every clinician. I think we went in thinking like everyone's going to love this. The adoption is going to be great. It's going to be perfect feedback across the board because it's a really cool, innovative solution and everyone is adopting it at scale very quickly. But it's just not true. I think we're still going to learn what the perfect fit is or what the best fit is, type of patient, type of visit, type of clinician, type of, collaborative visit, like co-visit or single, just a provider versus an APP and an MD. I think we're still going to learn more. It's not a silver bullet, and I think that's also okay. You're going to have people who really love it and use it for every single visit. You're going to have some who use it for only new visits or, their first intake of a patient, and some people who just say, I don't want to use it. I like paper or, I use Dragon and I'm good and I don't need a solution like this. And I think that's okay. It's a support tool for our clinicians and documentation.
I'm going to jump on that a little bit. So first of all, I'd say don't settle in on doctors. I mean, APPs, doctors, that's one thing we learned is they're all great with it. But one of the things was a big lesson to me. I had several doctors who tried it and quit using it. Don't consider that failure. So I would challenge the providers to be resilient and to be flexible. And I would challenge them that they cannot say that they haven't tried it or it didn't work for them until they had tried it for about 2 weeks or 100 encounters. Because honestly, it takes that amount of time for the human to learn how to speak to it in a way that they don't have to do a lot of editing of the note. And that's key. Doctors won't keep doing this if they have to go in and do a lot of work on the back end. It has to be a good note output. And so working with the providers and letting them know, this is what's expected. So I had several docs who had said, tried it, didn't work for me, got them to try it again. And they were so thankful because now they've fully adopted it. And they say, it's given me all the KPIs that you guys mentioned, hours back into my day. So that I think that's important to have the right mindset. The other thing was operationally. So we approached this with very tight partnership between our operations, senior leadership, and our clinical informaticists. These clinical informaticists do not sit in their offices and send emails. They are in the offices, in the workflow. They understand the workflow of the doctors, and that is incredibly important because if you're not at the in the office seeing the patients with the doctor, it's going to be harder to adopt. And then the last thing I'll say is I had one doctor, this is going back to the Dragon Medical One days, which by the way, before this was the most important thing I had ever done. I had a doctor who said, I was happy with typing for 6 months and I finally tried it after you told me to go ahead and try it. And she's like, I can't believe I wasted 6 months typing when I could have used Dragon Medical One. The same is true of this technology. I feel like this is going to fundamentally transform care delivery. And we have to be the leaders who get in there and help the medical staff become pioneers and adopt this technology.
Yeah, I think for me, it's similar lines. One, engagement and excitement don't necessarily precurse adoption, right? You can have clinicians who are so excited about it. They are tech forward, tech savvy, and they're super excited about this AI, but doesn't mean that they're going to be the high adopters or even meet the sort of utilization thresholds that you're hoping for. Brian had 100 minimum. We were at 5 per week was the ask of our clinicians. So that was one. And then second, I'd say definitely take the time to do sort of current state process mapping of your clinicians and understand where their gaps might be that ambient may not be the best fit. Easy example is, I'm a physician, my APP sees the patient first and does most of the notes. So it doesn't really benefit me to have ambient as much as the APP. That's one example, but there are so many others where just really understanding all of your users' specific and nuanced workflows will help you tackle adoption easier throughout the pilot.
I would just add that I totally agree with what Brian was saying about don't give up on the new users. And one piece of advice that we found that came out in our focus groups was that people who worked in clinics where there were other people in the pilot who were also using the AI Scribe, they found great benefit in that because there was someone there who was trialing it out with them and they could troubleshoot problems together. So if you're an institution who is releasing it, in waves or piloting and expanding, I would give it a try to do clusters. So if you have a group at one location, do that group before rather than spreading it out kind of. The second thing I would add to that is that when you're deploying this technology, it's really not like a one-to-one that you're turning it on for a physician. There's a whole ecosystem around this that you need to consider. Some to think about. One is the data privacy issue. When we're working with these AI companies, there's questions that have come up after the fact about what exactly they're doing with data and how is it being used to, fine tune or retrain their models and whatnot, and what are our current policies, and do we need to reevaluate those? Another, which is particular to the state of California, but probably other states too, is the process of consenting someone to record them, to get an audio recording. It turned out over the course of the pilot, it's quite cumbersome to do that for a physician, to do that for every single patient. So finding a better way to do that early on, maybe it's like your yearly consent to treat bundle that you have patients sign or something like that. And then lastly, this may also be unique to California, but you always have to consider unions that may work with the technology. Say if it was going to be used in an inpatient setting someday and maybe nurses would be involved with it, unionized employees may raise concerns about how AI is going to affect their work experience, and it's important to address that early so it doesn't present any sort of roadblocks as you try to expand on the use of the technology.
Great. We've had a whole bunch of Q&A here along the way, so I'm going to bounce around and see if we can answer at least a few of these. And I'll put these out there for the panelists, so if anybody wants to dive in on them, please feel free. We had a couple questions around working with startups versus more established vendors in the space, and I'd just be curious, for those of you who are looking at both, how did you think about that? Your comfort with a startup versus the importance of going with someone who's more established?
I'll take issue with that because I'll tell you, there are big marketing companies out there who have a large presence that a lot of people think are the quote leaders. They have a lot of money to put behind their product, but this is such a nascent field. I don't know that we know who is going to come out the big company in this space. They're still all evolving. So I don't think of it as little startup. I mean, there are some that I wouldn't even partner with because of data security concerns. But of the ones you would actually consider reasonable, I think they're all in the same boat going after the same goal.
I echo that. I'd say that, oh, sorry, Paul.
Oh, I was just going to say real quickly, personally, I look at the companies and see where they are in their Series A, B, C funding, because I don't want to enter a contract with someone and then they're very early on, and maybe 8 months from now they're no longer a functioning company. So I do think about that for startups.
I was just going to add similar comment. You have to do your due diligence, but I wouldn't say that some of them, what you would call more established companies, have a better solution for you than a company who might be in Series C and, going for a next round of funding. I think it's important you do your due diligence, you do your market research, you understand the team of the startup you might be working with, have a good relationship with them, and you pilot, and you have good metrics around your pilot.
Yeah, definitely meet with all these teams. Will be willing to meet with you. So find the 5 to 10 and really ask them for demos, and you'll get a different flavor, and you'll get a different team that'll give you an idea of what the future looks like with that company.
One of the first questions we got, and we haven't touched on this too much, is how big of a factor does price play for you guys as you were thinking about who to go with? Imagine it was a factor, but I'd just be curious if there's any high level color you can add on the importance of price.
It was a big deal for us because we have very small margins in our hospital system. I wish we had some big founder who threw millions of dollars at us and we could go innovate in any way we wanted and fail. We really didn't have that option. So we were very careful with our funding. And honestly, the encounter-based pricing, I think is fantastic. I mean, it was the game changer for us. It made it where if I only see 10 patients a month, I'm only going to pay $30. So it was a great deal. And it was also, my my contract is capped. So I'm actually a little lower than some of the other stated. I would work with your vendor. I think price is really important. I'd also be careful of getting locked into, let's say, a 3-year contract. Again, this space is innovating so rapidly. The last thing you want to do is get locked into a vendor who you find out isn't here next year because they go bankrupt.
Yeah, very important for us. I do think prices are already coming down, but I agree with Brian about not getting locked up in a long-term contract. And it has to be important though, because this technology is very expensive, and you don't want to waste valuable money that you can invest elsewhere. You want to make sure it's benefiting our patients and our physicians.
Yeah, I think for us, our situation, both vendors ended up having very similar pricing. So for us, it was a matter of clinician users. Which ones do you prefer? Which do you think will scale the best, given our clinician pools at MSK and our clinician volumes? And so the clinician preference was a huge driver for us.
Another question we didn't touch on too much was the importance of how these solutions fit into the workflow. So I'm just curious, obviously beyond the importance of being well integrated into the EHR, were there meaningful differences you saw between vendors and kind of actual workflow integration and ease of use?
Yeah, I love having Haiku integration. I feel like certain doctors in our organization, that's what they want, because that's their workflow. And they use, like, for instance, iPads, they'll use Canto on the iPad, and they want to have that Haiku integration. So that's been a real positive. I also, though, I'll warn you, I also think from a downtime perspective, it's not a matter of if, it's when you get hacked and you lose connection to the internet and you lose connection to Epic. There's an organization who went down. They lost their connection to Epic and they couldn't document. You want to have a solution that has a freestanding app as well, so that you can continue to function as an organization should some unthinkable happen and you go down. So I think it's important to have both, but I love the Haiku integration. It's also important. One more real quick, as this evolves, it's going to be even more important because you get these products will tee up orders one day, and you don't want to be operating out of 2 systems. You want to eventually be able to operate out of one. It's going to tee up your prescription and your chest x-ray. You want that right there. You don't want to have to go back and forth if you don't have to. Sorry to interrupt.
No, it's okay. I double down on integration into your EHR is key, especially for us. Our clinicians aren't going to use something if it's not a seamless part of their workflow. It's just whether you're an MD, APP, or RN, like it just needs to be a seamless part of your everyday work. And so being able to integrate into that everyday workflow is super, super important. I'd also say just one lesson learned from our pilot. Normally, when we implement new and innovative technologies, we do a lot of like workflow mapping and journey mapping and doing some earlier analysis to understand like the potential impact or change in workflow. We actually didn't do that for our pilot. And looking back on it, I wish we did. It probably would have given us a little bit more insight into how to best roll out for some of our specific specialties, or specifically, like Syrian had mentioned, for our shared visits between MDs and APPs and what that workflow looks like. So I do wish that we had done that for our pilot. So I would say that that's kind of a key takeaway that people might want to think about before moving forward with a solution.
I echo good integration with Haiku, for example. Extra clicks, even like 1 or 2 extra clicks, and you'll receive complaints about that. And then people with highly templated notes is not going to work well with that. A note that you just click through, just not going to work. And maybe it will in the future in some way, but it's not integrated in such a way in Epic that it will work with a templated note.
Got it. I know we're at time. One question we got a couple of, so if folks need to drop, please feel free, but we'll see if we can squeeze one more question in, because I think it's an interesting one. Is there anything that would make you consider switching vendors? And I'll ask that broadly, and again, whoever wants to jump in, feel free.
Yeah, these vendors go beyond the ambient documentation. I am with the person who's going to support practicing medicine in a different way than we currently are. In the United States, healthcare is not sustainable financially It's not sustainable from a physician burnout perspective. So whichever vendor finds it where it takes away my cognitive burden, not just to put a note together, but to do all those other things I do to take care of patients, chart review, order entry, that is the vendor that I'm going to partner with. I am not married to any one particular vendor.
I agree. I think that innovation is key. So whoever's taking the next step to further our patient and clinician interactions and clinician experience, patient experience, I think we would be open to switching if needed.
It has to, I mean, the market has to consolidate to some degree too. So there will be a few standouts, but again, going back to price, the price continues to come down. So at the end of the day, that's a very important thing to factor in.
Great. Well, I know we're a couple minutes over. Massive thank you to all of our panelists. I found this to be super informative. Hopefully the audience did too. For folks who are wondering, we did record this. We will be sharing this out. So feel free to go back and give a listen if helpful. Otherwise, thanks everyone for joining, and yeah, have a great rest of your Tuesday. Thanks.